Okay, good. You're in this room.
Okay, it's time to start our meeting this morning, and it's good to have everybody here, especially those online as well as here physically. And I'm gonna let Frank introduce our guest speaker, but first I'd like for us to go to the Lord in prayer and open this time. Precious Heavenly Father, we thank you, Lord, for your mercy and grace, God. We thank you for this day, God, and for your many blessings, Lord. We look to you in all things, God, and we pray, Lord, that you would just overshadow this meeting, Lord, that you would give us guidance and direction in all things. In the name of Jesus. Thank you. All right, Frank.
Well, good morning, everyone. And for those of you that are online on Zoom, thank you for attending today. My name is Frank Brown. I'm one of the council / board members for the Georgia Cherokee Community Alliance. And we're very thrilled today to have Dr. Ted Johnson from Emory University to come and present about Georgia year. I've had the pleasure of knowing Dr. Johnson, I don't know, 25, 27 years. We go way back when Wesley Woods Geriatric Hospital was in existence. I joined Emory faculty back in '89, and you joined
97.
97. So not quite as long as I have. Dr. Johnson is a professor of medicine at Emory. He's a professor in the School of Public Health also. And I didn't write it down on my notes, but I sort of remember he used to be an associate professor of urology.
That's true.
You are. There's probably a backstory on that, but I don't know. He's a chair in division, director of division of general internal medicine, and chair of family preventive medicine at Emory. So he's been very involved in a lot of different clinical work, research aspects throughout Emory University and the VA hospital in Atlanta. It's been a pleasure knowing him over the years. He's not only a great clinician and a researcher, but he's also a very personable individual that holds very high standards for ethics and the integrity and honesty of not only his profession, but within his personal life. So Dr. Johnson's going to tell us a little bit about Georgia Gear and some opportunities there. And then once he's finished, I'll make a few remarks, not only about the presentation, but a little bit about the Georgia community, the Georgia Cherokee Community Alliance, and what this may, how it may end up benefiting us long term, regardless if this grant is funded or not. So with that, Dr. Johnson, I will turn this over to you. Your mother would be proud.
Frank said your mother would be proud of that introduction. I am as well. And so it's a real pleasure to be here. I want to point out my colleague, Ms. Grayson Baxter, who works in the Georgia Gear office and keeps everything in order. And so really pleased to be able to be here with you today. The hardest part of this morning was actually finding the hub, and I'm glad that I did. It's a lovely center, and we're really appreciative of them inviting us and certainly hosting this meeting today. So Georgia Gear is, we do a lot in geriatric education, and we do a lot to provide aging resources. It's a group that is interested and funded to help older adults have better lives, connection, and success in their lives. So for me personally, my personal story in reflecting on my parents, I'm the child of parents with profound physical handicaps. So my dad had polio in 1942, spent most of his childhood in Shriners Hospital for Crippled Children out on the West Coast. My mother's mother had German measles, and as a result, she was born with one arm and some hearing problems and some visual problems. So part of my personal story is kind of that not feeling for our family that we were fully connected with communities and that we were looked at as others. We were looked at as people who somehow didn't belong. And so part of my personal mission is to help people be full in their lives and connected to life and community. And I think that resonates kind of with my choice of geriatric medicine. So Georgia Gear is a group of folks funded by the federal government who get together to get things in gear, to shift to another gear, and to gear up with other people to achieve similar ideas and values. And so if we have success in our funding request, and based upon the conversations that we've had, Frank and I got together, we talked about what we might do, extended an invitation to the council and the leadership to say, does this make sense to you? We'd love to partner with you. Does it make sense to you? And so in this diagram, sort of showing the Georgia gear here and HRSA there and Georgia Cherokee Community Alliance there, it really does try and demonstrate that if this turns out to be funded, there's a relationship that the Georgia Cherokee Community Alliance would have with the federal government, HRSA, in terms of doing things that are aligned with what HRSA wants to do in this program. I'll tell you more about that later. You would also have a relationship with us because we want to help you have success in your goals and in things that HRSA wants to have happen. HRSA, you may or may not have heard of before. It's part of the Department of Health and Human Services. They fund things like area health education centers in rural areas. They fund faculty. They fund discipline development centers, like they help increase the supply and distribution of nurses, doctors, and the like. And so we found them to be a good partner. Our team and me personally, we've had 10 years of different funded success to do different things in Atlanta and Georgia more broadly. So that's kind of the nature of what we're going to talk about. So let me go through each one of these parties to talk about why this might make sense, because we have shared value. If we don't have shared values and purpose, then it's not a partnership. This is from your website. We have come together on the basis of our need for community and to help and assisting our elders and youth or other needs as deemed as necessary by the Georgia Cherokee Community Alliance. We look to honor our elders, veterans, and youth, as well as our tribes to which we belong. And so when I was reading that and thinking about what you were interested in, I thought that several of those values were shared by us. If you look at what HRSA wants to do, this is their broad mission statement, broadly, to improve health outcomes and achieve health equity through access to quality services, a skilled health workforce, and innovative high-value programs. And I think that that's much of what you're trying to do as well. And then finally, specifically the program that we're funded through, which is called a GWEP, which is a horrible name, but it's a geriatric workforce enhancement program. So the purpose of Georgia Gear, Geriatric Workforce Enhancement Program, is to educate and train the healthcare and supportive care workforces to care for older adults by collaborating with community partners. So we're charged and we're interested first, but we're also charged with being out in the community and working with community partners to have a shared mission. So this is some of the information that the council actually considered in terms of, do we even want to sign on to any sort of application, and what would it be that we want to do? We're kind of familiar with that structure in that we've worked with a number of different people in the Atlanta communities and across Georgia. And in one case that we'll talk about a little bit more, Alter is an organization of Black leaders in the African-American community in the area of Atlanta that wish to change the Black church experience such that people, as they develop Alzheimer's, as they age, some do, that they would not be separated from the church by virtue of having Alzheimer's disease. So it's a whole program to teach parishes and churches about how they can accommodate members, lifetime members, who have become persons living with Alzheimer's disease. And what does the church need to do to support those people? How do you keep everybody in community? There's some very technical things about having breaks, allowing for people to have vocalizations or outbursts, and also this notion that there's meaning to remaining in community. And so when I talked to my friend about this program, I said, hey, look, wouldn't we'll write some money in to a grant. Wouldn't you like to do that? She's like, we'll pray on it, and we'll meet with our church elders, and we'll talk about whether or not to do it. And so we sat and waited for them to think about whether or not this is something that they wanted to do. And that sort of got us aligned. And so Alter is a name that Georgia Gear helped them come up with. Their former name was Dementia Friendly Faith Village Communities and African American Churches in Atlanta.
Might have been longer than that.
It might have been longer than that. And so one of the things that we helped them with is like, that's a mouthful. That's worse than wet. And so, so what we did is we worked with a professional branding and marketing agency that we had funded, and then we connected them, and they came up with this name Alter, which is, of course, altering or changing, but also the altar with an A-L-T-A-R, which is kind of their coming together place or gathering place. So a number of different partners, including the Department of Veterans Affairs. This is one place where I practice clinically, the Integrated Memory Care Clinic, where dementia is primary. And that supports people who are living in with dementia in the community. And we have a nurse practitioner-led social work model to actually support the patients and actually support the families that are caring for them. So on call for the Integrated Memory Care Clinic, you can have 45 minutes worth of conversation that's not very medical at all, but is all about, you know, what to do with somebody who's yelling at home all the time and how that's stressful. And so we try and develop and tailor our services so they actually meet the needs of the community. The Thanks Mom and Dad Fund is a nonprofit arm of a government agency that supports area agencies on aging. And one of the things they do is monitor contracts and services, make sure that people who are paid for providing services actually do so. And they also have a great way of actually getting money out, because sometimes working with the state of Georgia, and you may have experience working with other governmental agencies, it's like our 5-year work is actually 5 times 1 year. And so they were taking about 10 months to initiate every year's contract. And so we were trying to do 12 months worth of work with 2 months worth of approval. So we try and figure out ways in which to get folks together. But this really is a part, this is from our 2019 to 2024. This was our get together that we had right before the pandemic hit. So a lot of people in this partnership had to pivot and figure out exactly how to do everything that they plan to do in person online. And so it was a nice group of people, and it's really a shared governance model. We actually send folks out to our partners and interview them confidentially and say, what do you like about us? What do you not like about us? What are some of the things that we could do better? And we lead to a better governance and change that works for everybody. Let's get into the weeds a little bit about what this particular application is asking us to do. I'll blow up these 3 program objectives a bit more so you can see some of them. They have asked us to do some things that we've never done before, and one is a partnership with the Georgia Cherokee Community Alliance in a way in which to outreach to tribes and tribal organizations. We are also going very rural. We've been an Atlanta-based organization. They have asked us to not only be in rural communities, but also send people from our programs down to rural communities with the intent that as a result of their work with rural communities, that they'll actually stay there. And so we've never done that before. And so we come to this work with humility, with request for partnership, with and ask for forgiveness when we step into something that we just didn't know about. And it's really a shared learning experience. And we hope that you will feel that way because that's the way that people have told us that their experience is. So a little bit about this. In the state of Georgia, there are no Indian Health Services facilities, official clinics. If you go to the website and look at what medical services formally are available for people of the Cherokee Nation and other federally recognized tribes living in this area, it's basically a list of the Department of Veterans Affairs, which is great if you're a veteran, not so great if you're not. And then just trying to figure out what's the appropriate and clinically appropriate, culturally competent care that you can receive as you're a resident in the state of Georgia. So some of the things that we're doing is that we have folks who are on our medical staff now who have spent time out in New Mexico working for Indian Health Services for various times. We have folks, medical students who actually do visiting rotations. We have residents in our training programs who actually do visiting rotations in Indian Health Services locations. We'd love to begin to anchor that in the Cherokee community here in Georgia through health fairs and other contacts, bi-directional education and learning experiences, as well as trying to figure out how to locate people from here into areas in Oklahoma and other places that might be appropriate and meaningful. So the other thing that I'll say about us is that we know somebody who knows somebody. Usually if there's things that we don't know how to do, we usually know somebody who knows how to do them, or we know somebody who knows how to do them. So Tony and I were talking about ethnobotany, and so we just did a special event in ethnobotany with a faculty member at Emory whose name is Cassandra Quave, who is also a person with a physical disability. She writes about this in her book. So she is a single amputee, has one leg, and then stomps through all parts of the world on one leg, talking to elders in the community, understanding medicinal plants, understanding how they're preserved, how they're gathered, and understanding the chemistry of it. And so an example of knowing somebody who knows somebody that might be useful, and you probably know people that we need to know that we haven't met. The other thing that's kind of a big charge for us is to do work in memory loss and dementia care. And so I've heard a bit about how that might be a concern in your communities, and welcome an opportunity to share knowledge, share perspectives, and figure out how to do. Money. So here's the proposed budget. And when we propose a budget to the federal government, we just basically say, we've got together and we've proposed a scope of work and we've priced that scope of work out. And then we actually hand this money to you. You can hand some of this money back and saying, we don't know how to do this part of the work that we're doing together, and would you do this work for us? And there are also needs and services that we provide as part of the central core of Georgia Gear: evaluation techniques, marketing, online presence, those sort of things that might be of interest to you in terms of how you want to build your community. But you actually control this money and you figure out what to do with it and how to spend it. That's part of the relationship between Georgia Cherokee Community Alliance and HRSA, and are making sure that you have the ability to spend that money in ways that you want to. So here's what you said you wanted to do. These are some of the things that we think that we can provide. These are some of the things that came out of the brainstorming. This is not a final version of this. And as Frank started out and teed up, fingers crossed that we actually get this money. We figure that of all centers that are current centers, that about 2/3 to 3/4 actually make it through. We hope that we're well within that 3/4 or 2/3 because our program officers tell us that we're doing a great job, which is nice. But they're not the ones grading the proposals. And so we'll just see. Even if it turns out that we don't get this funding together, there's still things that we'd love to do together. So fingers crossed. We'd really love to work together, and we plan on working together, even if this doesn't work out exactly as they intend. So thank you so much for having us up here. We're really excited for this partnership. Thank you.
Thank you, Dr. Johnson. Appreciate it. Before going into questions, Dr. Johnson would let him recover for just a few moments. Just a couple comments kind of tied this together with a little bit more information or maybe reminders about who we are and what we are. The Georgia Cherokee Community Alliance, we are a community, and that's first and foremost. And we're a community of registered Native Americans, Cherokee citizens, who are really dedicated to Cherokee heritage, culture, and to fellowship. We are a nonprofit or non-political Native American organization. And so that's very important to remember that we represent the Cherokee citizens in Georgia, and we are really the official connecting point to the Cherokee Nation for that relationship to the Georgia citizens. And the material that was presented by Dr. Johnson, fingers crossed, hopefully it will be granted, but I would call your attention to a couple specifics there. One is the focus on really training healthcare professionals. One of the things as for citizens of the Cherokee Nation, there's always been emphasis at Hastings and on the reservation for training healthcare workers and being able to pay for some of their education, having them work in the hospital and tribal centers. There's not been as much of that emphasis in Georgia. But as we go along, we'd like to think about how can we recruit individuals in their high school years and their college years. And I don't know if you've had time to read the material on this little signage here about the hub, but a lot of the things they have on there are things that apply to us, that apply to all of our citizens in the state. And some of the things that we're interested in following are also things that were brought out here about helping to improve the care of the tribal older adult. Being able to partner with these community health fairs and educational activities. Even if we do not have this grant funded by the federal government, and this is going to be a follow-up question, by the way, so put you on notice. There will be other opportunities, or I would hope there would be other opportunities for Georgia Gear or some of the other programs that Dr. Johnson and his colleagues are involved with at Emory. One of the things on the educational activities, what are we talking about? Well, what are the things that impact our citizens? What are the things that impact our elderly? Diabetes, nutrition. As we get older, the risk of falls, so fall screening. Looking at what are the health services? Just mentioned that there are no Indian health services in Georgia. The central place where the removals began. So all these multiple removals going west, and yet there is no IHS center here or even outpatient clinic located. Will that change someday? Don't know. But it has always struck me that we lack that here in Georgia. So one of the things too that we need to be providing our Cherokee citizens, the community at large, is how do you access, how do you have knowledge about the health services? How can you leverage the use of the internet to find where those things are? There are services available. If we're like Stephen Mathis, may drive to the Cherokee Nation. There's Catawba in South Carolina. There's facilities in Florida. There's North Carolina, going to the Eastern Band. So there's things out there, but you have to know about them or to take that effort to find them. One of the other things that has come up in discussions with, and at least the last two meetings that we've had, is really about mental health. And that's one of the items that's up here on this thing for the hub is about mental health, depression, anxiety, trauma, alcohol, substance abuse. So those things come out a lot. And we need to be able to have educational activities in the years to come about that. And then the final thing is really about health fairs. And this is something that Dr. Johnson's team can really help with, especially with some of these medical students, internal medicine residents, as they attempt to fulfill some of their requirements or some of their interests, being able to participate in health fairs for some of the other things I mentioned, diabetes, vision screening, depression screening, all risk assessment, and being able to screen people, and then for us to be able to provide information about what can you do to maybe mitigate that, alleviate that risk, or where can you go, what can you do to see. And then that final thing on these educational activities, not only health related, but they're also about culture too. Tony Harris at Cherokee Gardens, for example, being able to have that it's already available for everyone, but being able to push it out there, whether in person or walk through the gardens with the Zoom, becomes an opportunity there. Being able to function as a community and community walks and that sort of thing. But anyway, I just wanted to take a couple minutes to kind of integrate some of what Dr. Johnson presented into what we would like to have in the future. Even if the grant's not funded, these educational activities, health fairs are things that we're committed to really trying to bring forth in the next 3 to 7 years. They're things that would be of great value to the Cherokee community here in Georgia. So with that, I'll go ahead and open it up for any questions. And I'm sure that Dr. Johnson is very willing to address any of those.
Yeah. What exactly is involved in getting an IHS designation? What's involved in that, and also what would be the advantages if we did have that designation in Georgia?
It's, you said it, it's amazing of all of the combined histories of our peoples that from Andrew Jackson and before and since removal, intentional removal of Native Americans and tribes from right where we are now. So that why there's no Indian Health Services here for people who are here is bizarre to me. I hadn't known that until HRSA started asking us to do this work, and I was like, there's no place here. So we do have partnerships with a GWEP in North Carolina. We do applicant in North Carolina. We do have partnership with a GWEP applicant in South Carolina. So here's what I would offer you as a plan. One is to get connection with Indian Health Services that are not in the state of Georgia. 2 is to work with them collaboratively to figure out telemedicine programs, hub-to-hub sites that would actually allow you to have Indian Health Services received here in Georgia. As somebody who spent a lot of time in the VA, a medical license in the VA is portable to everywhere else in the country. And so you can do all sorts of telemedicine across state lines, which otherwise you can't do. And 3 is that HRSA is not a lobbying program. And so as a federal program, they can't lobby or they can't pay for lobbying. But you can lobby and we can help you lobby. And so I do think it's a very interesting topic as to why.
So I'll make a couple additional comments based on my history. What happens with the Interior Department and then with the Indian Health Service, it has been very political over the years. I remember in 1983, was at a meeting with Everett Rhodes, who actually became the director shortly after that of the Indian Health Service. Was thrilled that a Native American was becoming the director of that program. It didn't last long because of the politics. And it was very unfortunate. And I think ultimately for Georgia, the federal government would have to designate specific funding for an IHS center here. And one of the arguments is that there's not been any central localization of a large number of Native Americans. We do have state identified individuals, but this may be one of the steps in my mind when I look at that. I've kept up with IHS activities over the years. I think that once we have a large community and show the structural need in this state, then I don't think we'll have a full center, but I think we could easily have an outreach clinic that's probably like for an outreach from, say, the Catawba, sometime the joint clinic. But I don't see that coming within the next 5 to 8 years for sure.
So one of the things that's interesting is that this ask from HRSA came for a reason. HRSA is responding to congressional inquiries about what are your programs and what are they trying to do. And so Grayson and I speculate on this a lot. There's like, 7 years ago, they were asking us to do work in Alzheimer's, and then they were mandating us to do work in Alzheimer's for about 10% of our budget. And then they were mandating us to do work in Alzheimer's for about 24% of our budget. So something's happening in the background here. The fact that this call went out to 47 centers across the country to do work in tribes and tribal, in partnership with tribes and tribal organizations. There's something that's happening that's putting a new sort of pressure. And locally, what that means, you're more expert than I am.
So since you're speculating, I will also address the question of speculation.
And we're recording this speculation.
Yeah, I'm aware, so I'll be careful on how to say it. Back in the early 90s, I was on a board that was also dedicated to Georgia Native American affairs. A board that didn't last that many years. But part of the goal at that time and some of the discussion was that we really need here in Georgia a cultural center, a Native American cultural center, a Cherokee federally recognized community that sets up a community center that's recognized by the Cherokee Nation of Oklahoma and perhaps Eastern Band. Once we have a physical structure back in the homelands where the original Cherokees were removed, then one of the things I've held over the last couple of decades, 3 decades now, is that would be some of the beginnings to be able to leverage Congress to go ahead and do something like an IHS health center, but it's more than that. It's also the cultural. And I think we have an advantage because history, while history has been unfair to Native Americans throughout the United States, been especially true to the Cherokee. And you mentioned the name of a former president that was very involved in going against Supreme Court. And I think that those are opportunities to leverage. And there's a lot of discussion today about equity and about fairness. And the Native American communities are often neglected on those discussions. Long-winded answers.
No,
to a
I mean, these are
specific
complicated
question.
issues and
What-
directionally.
What about other questions? Paul?
Has any of the other chapters, nationally, made an application, to the Cherokee Nation for a grant to establish a cultural center in the state?
Steve, can you address that? You might know more about it.
We do have very close partners in our GWEP programs with the GWEP program in Oklahoma. We've had preliminary collaborations and conversations about how we actually, on the PERSA grantee side, might be more closely collaborative. They currently don't do a lot with Cherokee Nation. They have other tribes that they're working with. They're based out of Oklahoma City, but they're open to talking about, kind of what comes next.
Other questions or comments? What you're thinking, you already addressed it already when one of my questions about what the probability is, because a lot of times program directors can give a pretty good indication. And you kind of indicated maybe even 2/3 of the established program to be funded. But it also speaks highly with program directors to have a good feel for these committees that are evaluating these programs. I used to be a reviewer for Native American programs included, but also for health services research with the federal government many years ago. And I would say that the program directors are pretty accurate being able to have a gut feel as to one, how much money is available, then how many grants could be funded.
Grayson does this as well. Several of our people on our team that wrote the grant spent the last 5 years reviewing other grants, and so they know how the scoring works. And we actually had one of our team members use a scoring sheet and use our application and sort of figure out what we did and what we didn't have in there. So I think that we've done everything that we could to ensure our success, and we're well recognized within the community of people who have these grants as what they say is that we do a lot of innovative programming and do a lot of meaningful programming. So
I've been very impressed with how fast you got that together.
please.
Yeah, this is logistics. If we get the grant, will Georgia Gear be very supportive of us in our administration of this grant. You know, we're fairly familiar with the auditing, bookkeeping, what we need to do behind the scenes, but just, will you have staff that'll help us, support us getting it off the ground?
Grayson's giving you a big-
Hey.
Not only do we have staff, but we bring them here. So let me give you some for instances. So for instance, we have a partnership with the Atlanta Medical Association. The Atlanta Medical Association is a branch of what's called the National Medical Association. And if those acronyms don't mean much to you, it's basically how African Americans were excluded from white-only professional societies and therefore had to set up their own independent professional societies. And so the Atlanta Medical Association is about 120 years old professional society of physicians and chiropractors and dentists who want to do education with their membership about problems that are meaningful to their community. So we have some money that we give them, and then they invoice us for what we've done, what they've done. And then here's kind of the support. HRSA doesn't pay for money. I'm sorry, HRSA doesn't pay for food, and HRSA doesn't pay for venues. But HRSA does pay for administrative expenses, and HRSA does pay for publicity, and HRSA does pay for outreach, and HRSA does pay for speakers, programs, and travel and stuff like that. And so confidentially online, we have situations where they'll give us an invoice and we'll say, you need to say this on the invoice. And then they say, oh yeah, that's right. And then they give us the invoice back and then we pay them. And so if they need to have an event where they have a venue and where they have food, then they pay for that with their other income. And then we pay for things that frees up that money. So that's kind of the secret sauce of how we're not going to abandon you and give you money that you can't spend and give you money that you can't connect to the things that you want to do. So going one level up, for instance, more at a health fair, we can buy you scales, we could buy you home blood pressure monitors, we could buy you tables, we could buy you chairs. We can't pay for the venue that you're at, but you can imagine that having the money to do those other things begins to facilitate this actually happening. So yes, we stand by you. We get a bad grade if we don't spend the money. And so one of our partner organizations actually got more than they had budgeted because they were effective at translating investment into outcomes. And so other people who couldn't figure out how to spend money gave that back and we directed it. So we want you to.
And what would a cultural center look like? What should it look like, or what would it look like? Doesn't get in my mind, you know, what we're talking about.
You were talking to me earlier about the garden. That's one example of what a cultural center might have, but I'll
Right, so you're just, you're asking Frank Brown for his opinion.
Very political of you.
You've already hit on part of it. I would look at a building, a physical structure that's on land that is set up as a 501c3. So it's a nonprofit. I would say that building would be at least 2,500 square feet minimum. Ideally to be on probably at least 5 acres. So part of the outside would actually incorporate Native American gardening, but also other things that were central to Cherokee tradition, heritage, and fellowship. So even the playground for stickball or fire pit, various things there. Be ideally located to running water. The building itself, and I've been to various cultural centers, both from Native American, but also in other parts of the world. And part of that, what's there needs to be an administrative arm that has education, being able to provide to the public, and hopefully not only as somewhere where the Native Georgian Native Americans can go to, Cherokee citizens, but also for the community at large can go to and learn. and then have areas that would be for exhibits to portray some of the central important cultural heritage aspects in that building. So I think those would be core components that would be necessary. And then the other thing, and this is forward thinking, that if, say, this grant's approved and so later on in 5 years, there's a renewal. And if there is a way to come up with being able to do this in collaboration with Cherokee Nation, then having a part of that building that's designated for health-related issues, or health related training, or health-related educational activities, screening, but then we could incorporate there, how do we kind of an outreach component to the citizens here in Georgia about we're giving guidance for future job, for future training, to be able to not only kind of be part of the mission objectives for here, for the health education training toward older adults, that would include that. So that's my idea to being able to do that. I don't see that happening in the next 3 to 5 years, but I think it is something, especially with Steve's interest, and we've talked some more superficially about this, but I think it's very realistic to do that. I'm more confident that this group can do this than the previous board that I worked with back in the early 90s. I mean, we had a lawyer involved, and we're looking at some opportunities there. But I think this group really represents the community, a true community at large of Georgia Native Americans, Cherokee citizens.
He's been thinking about this a little bit.
I'm careful not to push my thoughts on others. Yes, sir.
This might be a naive question, because I just don't know how this would work, but it sounds like what you're describing as far as the cultural center would be, it'd be great to like build something like that, like where New Achota is. I know that's a state-run facility, but everything you're describing, it would, if you replace the building that was there with something larger and more comprehensive. I don't know if working with the state is feasible as far as getting that kind of thing done, but I wonder if that's something that's.
Yeah, you're not the first persons have thought of that, and I think that's I think it's very appropriate. Part of that, though, again, is some of the politics there. It's not just state; we're talking also the federal component there. But there are probably some options there, or even next door. But that's an excellent area.
Yeah, and I don't know how much land is a cheap van house. That's not that far away either, but.
No, there are opportunities out there, and over time, a lot of them are really hindered by cost, but then also some of the politics that are involved. And you really got to have political advocacy to do some of this. Like the community advocacy will drive that, but it is doable.
I spend a little bit of time running from museum to museum, and one of the funniest museums I've ever been in was the Go Fishing Museum in Perry, Georgia, which was basically based upon one governor's wish to put something back in his hometown. And so there are interesting things that happen. The other thing that I'll say is that Thursday I had my second visit to the Smithsonian history of the Native American peoples museum that's on the mall. It is a different museum, and it sounds like what Frank described more than the National Gallery of Art, for example. It seems designed for purpose in terms of both cultural and convening spaces and appropriate connection with the land, even though it's in the middle of the city right next to the Capitol building. So
A lot of people look at museums being indoor, but you have a lot of open air museums that are even more impactful. Yes, sir, you have.
What collaboration would be necessary to launch for a telemedicine program?
I have some ideas about that. So with one of my other hats, I help with primary care outreach for a program called Georgia Memory Net. And so what we're trying to do is put brick and mortar dementia assessment clinics near where people live in Georgia and not just have everybody wait 18 months and then drive to Atlanta to be seen at Emory. So there are 7 different brick and mortar places across the country. And there's also a collaboration with the Georgia Department of Health to actually set up remote stations in local county departments of public health where people can actually be helped with all the Zoom technology and actually have their evaluation online. And so they connect with our centers in, do you remember? I don't remember. They connect with our centers in Atlanta and connect with our centers in Columbus, and they basically get the evaluation in their community's Department of Public Health. Political, but I could see if we could get the Georgia Department of Health to agree that we could certainly continue to do memory assessments, but to figure out whether the Georgia Department of Public Health would allow Indian Health Services in either North Carolina or South Carolina to actually telemedicine into our departments of public health. That's in my brain the easiest way to do this. We already have a mechanism to do it, but there's probably some other partnerships that might be available, like partnership with the Department of Veterans Affairs, and actually have IHS telemedicine. That'd be like federal agencies working together.
Yeah, so, and I agree with everything that Ted mentioned there, even expanded it some. One of the things that with telemedicine, and telemedicine, by the way, has been around for over 40 years. Used to take a tractor trailer hold equipment, but even in the early 90s at Emory, we were working on a lot of the telemedical applications. Doing that in Georgia, just like what was stated, there is an opportunity perhaps that even with, say, Cherokee Nation based in Oklahoma, have telemedicine here. Problems we get into are regulatory. We get into issue about state laws, the practice of medicine across state lines. For some reason, the United States has this individualization that a license is good for this location, and then you have to have another license for this location. And that hampers things. And there's a lot of things on this interstate commerce and all that, get it. But for someone in Oklahoma with a medical license there to practice, in order to do that here, they really need to have a medical license for Georgia. Then you have the other requirements that you have to see the person as a patient in person the first time, and then do telemedical thereafter. So there's a lot of hurdles that have to be jumped through. And a lot of the telemedical that's done now, it's already available for most of the citizens of the state. But it's establishing that the provider is physically in Georgia, the patient's physically in Georgia, and then that's documented in the medical records. So it is something that we can look at. It's something that needs to be done, especially to get get healthcare to those rural areas, not only for Georgia Cherokee citizens, but just for rural communities at large.
There are some states that have easier compacts with each other. We found this out during the pandemic when people left their homes in Georgia to go to Florida or to Alabama or to North Carolina or to South Carolina. It turned out that it was easier for us to work with certain states versus others. And so whether or not South Carolina and North Carolina have better compacts with Georgia than Florida does is kind of the question. So there's a pathway to figure this out, but it's complicated.
That was going to be my next question, would it be an advantage to liaison with other at-large communities?
I think there's advantages to liaison regardless, and the telemedical may be one of the additional reasons. But I think that we have a lot to learn from other community alliances, and perhaps others have things they can learn from us, but it is a learning environment. And if someone finds out something that works well, then we should leverage it. You mentioned about the humility, about something goes wrong and being able to have grace over that.
Yeah.
Same thing with us. I mean, we learn, and there's a lot of, it's really finding the opportunities out there and being able to take advantage of those opportunities. And I'm afraid a lot of times we don't know all the opportunities that are out there.
but we know people who know people.
Yes.
Sounds good.
I believe it was a 5 or 6 year budget
Yep.
plan. Providing that it gets accepted, what's the time frame for year one? Or what is that?
July 1 to June 30th.
And the programs or things that are available would be available on that date to us?
Yeah, we should find out in late May whether or not we're funded for July. I think I said this earlier, but it's 5 grants of 1 year because it's not we say it's grant because I think everybody knows what that means. But HRSA calls this a cooperative agreement, which I say that we agree to cooperate with what they say, which is kind of what a cooperative agreement is. But actually, if you have good conversations and shared goals, it actually works well. So we can do whatever we want the first year, and then we get approved in what's called a non-competing continuation to get our second year, and then our third year and our fourth year. So the first year, there is some grace in terms of you need to plan what you're going to do. I think that we're kind of shovel ready. I think that we know what we want to do, and we've done a lot of thought beforehand that's not even in the application to figure out how we go right away. Gear up.
So what's not in the application was that we actually gave some thought to this, the board, and put together a tentative 5-year plan that would incorporate some of the educational activities, some of the health benefits, whether they would become real, are they realistic? I think they are. I think that's probably an 80% probability. A lot of the hesitation on my part would be, you really need nursing students, med students, residents from Emory, or someone providing that. You need to have a funded source for blood pressure costs, cuffs, or testing for sugar or vision testing. But that's where the equipment and things come from, and that's the funded source. So I think, it's aggressive. I think it would be doable that if it is funded July 1st, that fall we could actually do either an educational or health fair, and then do another one probably the following June, probably there, maybe to Chiefs meeting. Probably needs his blood pressure check.
One of the things that I like about this opportunity and just the application itself is the kind of permission to dream. I think that's really a big part of it. The folks that we were telling you about the Altar program, we asked them to expand their program to 7 additional churches in the state of Georgia. And the result was that they went to 74 churches in how many states?
17 states.
So I think that this notion of you get somebody who's crazy enough to do something crazy, it can really be good.
One other thing I was mentioned too, website, we haven't talked too much about that some of those monies can be used to help augment the website. And one feature on our website, as we develop it, that would be really cool to have, especially related to health opportunities and health education. And this would be a great opportunity to get that. Any other questions coming? Okay, thank you very much. I really appreciate both of y'all coming and being with us today. And there may be, after we finish this, there may be some individual questions. And I think turn it over here in just a moment. There's going to be a lunch and you are definitely invited.
And there is, I apologize, there is one question from Catherine online.
Hi, Catherine.
Catherine, can you hear us?
Yes, can you hear me?
Yes, we can.
All right. I'll try. I'm a talker. I'm sorry, but that just comes with the blood. But my great-great-grandmother was born in Georgia. She was removed from Alabama to Oklahoma. My grandparents grew up in Cherokee territory. At some point, my grandfather moved to Southeast Oklahoma, which is Choctaw territory. So I've got the Choctaw blood on the other side because my dad married a Choctaw. But and then I came back to Georgia in 1979. So I have had a quest. I still have a quest, and won't go into why it's hard for me to get the proof as far as my great-great-grandmother is concerned. But I'm in Douglasville, which is west of Atlanta, And everybody, I mean, almost every single person I talk to has Cherokee blood. And we know in this group, we know in other respects that a lot of Cherokees did not leave and a lot of Cherokees came back. And in my studying and in my researching many years ago, someone told me that the federal government does not recognize that there are Cherokees in Georgia or any other native tribe for that matter, because if they recognized that they were here, they would have to provide medical services. And a lot of what you're talking about there is the medical services in other states, but we don't have it here. And if this is true, then this is part of the reason is because they don't recognize. And so it seems to me, because these people that I say, oh yeah, I'm an eighth, I'm a fourth, you know, just it's something that is so common. And it just seems like that part of our task is to prove our presence, to prove that we are here and that we do have a say and that we do need medical services and that we do need those things available to us. Right now, my daughter is going to graduate school at Harvard. And if we had those kind of things available, there would be help. You know, but I'm in Georgia and there's not any specific help. So a lot of what you're talking about does have a lot to do with we need to somehow, and it's more of a comment, but it's a question of how can we get more proof that we are here? Because I know many from the various festivals that I've gone to that are 1/2 and 3/4 Cherokee. You know, but the federal government still says we aren't here. You know, so I mean, is this information accurate?
Frank, I'll let you start and then I'll offer something.
Yeah, it ends up being a really hot button question, not only here, but really throughout the country about federal government recognition of certain groups. And part of that is based on actions that the government has done. It is based on a lot of politics. Even for registration of citizenship being given a number. I'm 7296. And why do I have a number? So there's a lot of things that are not fair. There are a lot of things that could have been done better in the past. And we look at the roles that are used for the Cherokee to determine eligibility and blood quantum. A lot of that historically was not fair. And but it is what the rules are with the federal government. And being able to come up with what is a better method to deal with that, that I think is probably the ultimate question there. What can be done better? And without getting into a lot of details, there are some DNA analysis that can be done that can help address that to some degree. Nevertheless, under the current federal laws, under the current federal recognition that are in place, they are not necessarily fair, but it is what we have been living under for at least the last 119 years.
I'll offer an analogy where my people are from Oregon, and so they left Ireland and went to Oregon. And so I was at a meeting this past week with some folks who are doing HRSA work in Oregon. And one of the things that came up was, why are there so few African-American people in the state of Oregon? And so the people in the state of Oregon gave you 10 pages of why there are no African-American people in Oregon, from territory exclusion to it being part of the state founding constitution in 1859 versus prohibitions on owning property and all sorts of other ways in which people were either removed or not welcomed. And so I think that part of what you're saying is about awareness and people being seen is kind of teaching the collective history broadly to folks who don't know any of it because it wasn't part of our school.
Yeah, and a lot of things just not fair throughout history. My grandmother or great grandmother, when in Oklahoma, did not have a marriage certificate. Therefore, one half the family lineage not counted. So I mean, there's all sorts of things out there, injustices that have been done. They should be recognized. They should be discussed. And as a community, we need to try to, address the things that we can address. And on the political side, the politicians, the people that make up the rules, those are the ones that can, discussions with them can be had. Any other comments, questions before we finish up on this one? Steve, should I turn it back over to you?
You're ready.
I'm ready.
Shut that.